Okay, we can get started. Welcome, everybody, to the Musella Foundation's Brain Tumor Awareness Month webinar series. Today's topic will be a new hope in treating metastatic brain tumors, recent advances and opportunities. Our guest speaker is Dr. Tawbi. He's a co-director of the Brain Metastasis Clinic, Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center in Houston. Thank you.
Thank you so much, and good evening, everyone. Thank you for joining us this on the Sunday evening for this. Just wanted to start by thanking Dr. Musella for the opportunity to present here and to be with you this evening. It's a real pleasure, and having heard about some of the achievements that the foundation has done, I really think there's a lot that we can learn from each other and work together towards improving cancer care for all patients, including patients with metastatic brain tumors. I also want to start by thanking Gisela Sanchez specifically, who is one of our star APNs that also kind of made the connection with the Musella Foundation, and will be, I'll discuss her role as a patient navigator a little later. Last thing I'll say is I'm presenting on behalf of my colleagues, Fred Lang and Jing Li, who are both co-directors of the Brain Metastasis Clinic from the Neurosurgery Department and Radiation Oncology Department, and thank the institutional support from Liz Burton and Andy Futriol. So what we're going to do today, again, just to kind of give you a little background about myself, I'm a professor of melanoma medical oncology, so I'm a medical oncologist by training, not a neuro-oncologist, and so been at MD Anderson here over 5.5 years now, but previously was at the University of Pittsburgh, where I also treated a rare cancer called sarcoma, so I have a lot of experience treating rare entities. And also was involved in phase 1 drug development. So kind of all of these different kind of tracks have led to me being very involved in the management of patients with metastatic brain tumors. And so to start off, I think, again, speaking to a foundation that's really focused on primary brain tumors, it's really important to highlight that while primary brain tumors remain very difficult to treat and really recalcitrant to treatment, brain metastases are kind of emerging as a really major player in other solid tumors. And so simply because of the prevalence of other solid tumors, the incidence of brain metastases becoming significant 8 to 10 times more than primary brain tumors. And the estimate at this point is up to 30% of patients with stage 4 cancer, solid tumor that is, will end up having a brain metastases during the course of their illness. And unfortunately, we know that limits survival significantly down to only 3 to 6 months in most cases. And so when we talk about brain metastases, we always discuss what we call the big three. So lung, breast, and melanoma are the most significant in terms of being able to induce brain metastases. I show you in this graph kind of other slivers of other cancers that honestly, as we start seeing extended survival in each disease, we actually start seeing more tumors that go to the brain. And so of the three, I will also tell you that melanoma is considered the one that has the highest propensity to go to the brain. So currently, the multidisciplinary management of brain metastases is very important. So we always have surgery involved, and surgery could really be curative in cases that had a single brain met. And it's also very important in palliating symptoms. So if patients present with difficulty walking, or seizures, a surgery can really take that away almost immediately, and patients improve quite dramatically after a surgical procedure. Radiation has been really the mainstay of treatment. So whole brain is considered, or whole brain XRT is considered generally palliative, but stereotactic radiosurgery is kind of emerged as a really mainstay of therapy and very active and potentially curative in smaller tumors, and can tackle multiple tumors. The main limitation of these two approaches is they only work on the tumor that you go after. So either the tumor that you take out or the tumor that you radiate, that's where it works, but it has no impact in other parts of the brain, except whole brain and not in many cases either, and then has no impact outside the brain. The other thing we realize is actually our patients have to go run around different clinics. So when I see them in my melanoma clinic and I identify a brain metastasis, I have to send them to a radiation oncologist who could be on a different day of the week, to a neurosurgeon who could be on another day, and trying to coordinate all of that results in a loss of time for a population in which every minute matters. So that's really important. I'm going to focus a little bit on melanoma, partly because that's what I do, but also so that I think it's a really great illustration of how much progress has been made in the management of brain metastases. So I'm sharing with you a paper that was published by one of my colleagues, Dr. Davis, back in 2011, 10 years ago, that showed that brain metastases had such a dismal survival, as you see on the right side, with less than 20% alive at even 1 year. And in brain metastases from melanoma, we also experienced that a lot. The day I diagnose a patient with metastatic melanoma in the lung or liver, if I check their brain, 40% will actually have a brain metastasis. And there has been some series showing that by the time of death, almost 80%. So it's a huge issue for our patients with melanoma. But the important thing here is, again, when I started treating melanoma back in 2005, for me personally, at the time, the only treatments that we had available were high-dose IL-2 and dacarbazine, and the 5-year survival was less than 5%. And in the last 10 years, I've been fortunate to not just observe, but participate in the development of these new drugs, both immunotherapy and targeted therapy, that gotten us to 12 approvals. I can tell you that we're about to witness the 13th approval. And most importantly, the 5-year survival has gone above 50%. So here's a survival curve, and I know hopefully you've seen survival curves before, and I'll show a bunch of these as medical oncologists do. But what you really want to see here is at the end of 60 months, which is 5 years, more than 52% of patients, or 52% of patients, are still alive when they're treated with combination immunotherapy with nivolumab and ipilimumab. So that's amazing progress, 10-fold increase in the survival of patients with melanoma in the last 10 years. Interestingly enough, however, if you look at the collective, all of the phase 3 trials that have actually led to approval of those agents that I just mentioned, up to 7,000 patients. And out of those 7,000 patients, do you know how many have brain metastases? Exactly 0. Not a single one of those patients was allowed to be treated if they have the presence of brain metastases that are not treated with either radiation or surgery. And I share with you this one patient of mine. I was trying to put her on one of those studies, and you may or may not have seen scans before, but this is a patient with a lot of tumors. So you have some tumor here on the right side in the axilla. There's some tumor in the adrenal gland, some in the subcutaneous tissue, even in the bone. So this patient was in a lot of pain, and at the same time was, I was trying to put her on one of the most exciting clinical trials that we had. And of course, as it's required by these studies, I had to do a brain MRI. And with this little tiny white dot that you see there, she was unfortunately excluded from the clinical trial. Although at this time, I knew that her extracranial disease was more important. I had to treat this with Gamma knife and probably wait 4 weeks before I put this patient on study. So that just highlights the fact that this is a real problem, that those patients are excluded. And the question is why? Why are those patients excluded from clinical trials? Most of the time it's because this is kind of a traditional thing. And I have to say, we were at an FDA workshop in 2019 where even one of the FDA directors talked about how this is a copy-paste problem. It's in every protocol just because that's how it used to be. But there's also some concern about those patients doing worse, concern about immediate neurological deterioration. But more importantly, this concept that these drugs actually don't penetrate the blood-brain barrier, and maybe immunotherapy is not going to work because immune system is supposed to be not act in the brain. We call the brain an immune sanctuary. So there is some reason to it. And if you look at what we know, I mean, obviously the brain is very well protected. You can tell from the structure of the skull, one of the hardest bones that we have, and the way the interlocking plates are set up to kind of diffuse pressure, even the vertebral bodies to protect the CNS. And under the bone, which obviously is a lot of protection, there's also multiple layers of protection around the brain. So there's the leptomeninges, and these are 3 different layers of coverings. The outside one is called the dura mater, and it's one of the hardest fiber structures in the body. And then on top of that, the the brain really almost is floating. It's not actually touching anything through the arachnoid space and the pia matter. And even microscopically, if you look at how what separates the stuff in the blood from the brain itself. So first you see that there's so many tight junctions. So I'm sorry. The vessels have really very tight junctions, and then they have on top of this pericytes outside, and then the astrocytes also come and kind of support this whole thing. So there's a physical barrier, and then there's even a biological one. So there are pumps on the sides of these endothelial cells that even if a drug tries to penetrate, they pump it right back into the blood. So it is a real thing, this blood-brain barrier, and it's very effective at keeping things out. But once it actually allows tumors to get in, that changes a little bit. So anyway, I think those are kind of the main things that are usually mentioned as reasons to exclude patients. And then maybe therapeutic drugs are not the right thing to do. So you should do surgery or radiation. Only after you control brain metastases, you can bring those patients back to clinical trials. But we have proven that to be wrong. And here's how. So this is one study that I was involved in. This is a brain metastases from melanoma in this patient at baseline, and obviously a pretty large one. And I can tell you that with a drug called dabrafenib, where in this particular clinical trial, we actually, those patients were allowed to be we're not required to have no metastatic tumors to the brain. And with pills in a few days, not even these week 32 scans, these tumors shrink down significantly. So we really think that when this blood-brain barrier allows a brain metastases to set shop and to actually grow, then it actually becomes more porous, and it allows drugs to get in. And so we got some really great responses, and that led to a clinical trial that was kind of a landmark called BREAK-MB. And now we know that with combination targeted therapy, you can get response rates that are really high in the brain. So 58%, still a little lower than extracranial responses at about 70%, but 58% shrinkage of tumor, objective responses. So that's impressive. But what we also learned from this study called COMBI-MB is the fact that the duration of response in the brain with targeted therapy is more limited. So the PFS is outside the brain is about 10 months, inside the brain was only 5.6. So that led us to think, so targeted therapy helps, but its durability is not that great. What about immunotherapy? So when we're looking at immunotherapy, ipilimumab or anti-CTLA-4 was one of the first drugs that we studied. And this is a study led by my colleague, Dr. Margolin, where patients without brain metastases, we now have about a 15% response, but most importantly, the responses are very durable in melanoma. So you have this tail at the end of the curve. So she ran the study through the cytokine working group in patients with brain metastases and showed that the intracranial response was about 10%, so not very far. Most importantly, there were durable responses with immunotherapy. So that was a landmark study. The other thing we learned from this study, so again, you see that tail at the end of the curve, we also saw that patients that were on steroids at the time of initiation of therapy, so this blue curve, did not do as well. So we know that that's one limitation of immunotherapy. What about single agent PD-1? So pembrolizumab is one of those drugs that has been used in the brain as well. So in patients without brain metastases, the response rate is about 40%, and those responses are really highly durable. In patients with brain metastases, this was a study that was led at Yale by Sarah Goldberg and Harriet Kluger. It actually showed that in melanoma patients, the intracranial response rate was 22%. In patients with lung cancer, it also was about 33%. Importantly, again, those responses were really durable, meaning once you got a response, that response continued. So I actually personally led a trial that wanted to look at, so if IPI works alone, if single agent PD-1 works alone, what happens if we put them together? And we know that in patients without brain metastases, when you do those two drugs together, you get great responses. So 57% response rate, I consider it the most potent immunotherapy that we have. It comes at the risk of a bunch of toxicity, 55% side effects, mostly immune-related side effects, but it is the most potent. So we wanted to study it and see if that works in the brain. And sure enough, we did a study that was in 28 sites and 118 patients. And this is one patient that was at baseline with a large tumor in their brain. and with significant edema around it. And this is after 1 year of therapy, it completely disappeared. So we actually really have a great response in the brain. We actually observed those responses, not in 1, not in 2 patients. We've observed them in exactly 55% of patients as well. So the same response you get outside the brain, you get inside the brain. And all of these responses are durable. So you see this progression-free survival at 1 year of about 60% in the brain, meaning those patients, once they respond, they're not progressing in the brain anymore. And this is the 1 year overall survival, 82%. So remember when I showed you in 2011, the 1 year survival was 20%, and now it's 80%. And I can tell you, we've actually updated this data. I have the 3-year data that will be reported later this year, and it looks as robust. So we feel that IPI and NIVO has really made a great impact in patients with melanoma brain metastases, and kind of almost leveled the playing field. So now you can actually have cures for those patients. This was published in the New England Journal of Medicine and has really changed practice in many ways. But I know that as we do this, we've actually answered some questions. There's still a lot of questions we haven't answered. So for instance, patients that are symptomatic or on steroids, we actually had an 18-patient cohort in that specific study. Unfortunately, only 4 of those patients responded. The ones that responded did really well and had durable responses, but only 4. So we really have to think about ways to help those patients that need steroids. It doesn't seem that immunotherapy is capable of reversing everything. We're also studying other combinations, trying to decrease the toxicity if we can, or look at other combinations with targeted therapy. I can tell you at MD Anderson, this is just a quick snapshot of what we have for brain metastases just in melanoma. And you go to most centers and they may have 1 or 2 trials, or maybe none, that are dedicated for brain metastases. We actually have 6, where we try to kind of go after each of the different sites of disease and kind of layers. Like if you've been treated with PD-1 before immunotherapy and now progressing in the brain, we have several trials. If you have BRAF mutation or not. I'm not going to go into details over these. I'm happy to go through them if there are questions. And we have a very strong intrathecal program for patients with leptomeningeal disease. And my colleague, Dr. Gisela, will be presenting at ASCO in a couple of weeks the results from this study with intrathecal nivolumab. But there's still a lot of other questions. How do we incorporate this with radiation? We still don't have a good answer for that, and we have a lot of trials in that space. And I also want to mention, again, this is melanoma. I'm telling you, I'm focused on melanoma because I'm a melanoma clinician, but I want to treat other cancers and learn how to treat other cancers that go to the brain: renal cell, lung, and breast cancer. And I have to say, breast cancer has made a great impact as well. So here's what you need to know for breast cancer. Not all breast cancers really go to the brain at the same rate. So if you have 2 particular types of breast cancer, go to the brain much more than others. One is called triple negative breast cancer, or TNBC, and it's almost 3.5 times more likely to go to the brain. And the other one is called HER2 positive breast cancer, and that's 4 times more likely to go to the brain. And in those particular patients with brain metastases, there are some treatment that have shown activity. So here's neratinib, single agent, that actually induces responses in the brain. So these waterfall plots, everything that you see below the waterfall plot actually, or below the vertical line, tells you that these things are shrinking. And then if you start combining drugs like neratinib and capecitabine, you start having response rates of 49%. And interestingly and importantly, and this is a very important point, most of these drugs have been designed so that they don't enter the brain. This particular pharmaceutical array, now this has been bought by other pharmaceuticals, actually designed the selective HER2 inhibitor to get into the brain. So it was actually designed with the main molecule and its metabolite penetrate the brain better than most HER2 inhibitors. And when this was tried in a phase 1 trial in combination with capecitabine and trastuzumab, the response rate in the brain was really impressive at 42%. So what they did after that is a randomized phase 3 study called HER2 Climb. And this was actually, I think, again, part of history, to be honest, because this was one of the first breast cancer studies. If you look at the eligibility criteria, it says untreated brain metastases that were now allowed on trial almost for the first time in breast cancer. Obviously in other cancers that hasn't really penetrated, but you have 2-to-1 randomization to this triplet with tucatinib versus trastuzumab and capecitabine alone. And sure enough, this worked really well. So the hazard ratio is 0.5, which means that there's a decreased risk of progression by almost 45% if you got treated with tucatinib on top. And that also improved survival. So this ended up being FDA approved. But what I really want to share with this particular group is the fact that most of the benefit came from patients that had brain metastases, because that's what this drug was designed to do. It was designed to get into the brain. And look at this benefit, more than 52% reduction in the risk of progression, intracranial and extracranial, but that's how effective this ended up being. Again, this is a New England Journal paper. Dr. Murthy is actually, Rashmi Murthy is one of our clinicians that is in the brain met clinic and sees patients with us who led this study. So as we started seeing that these, systemic agents are making such an impact in the brain, I have to say that MD Anderson's leadership had recognized this now a few years back in 2016 and put together something that we call the Brain Metastasis Steering Committee. And even at the time in 2016, that was shortly after I came to this institution, there was a really strong, kind of belief that we need to do something different for patients with brain metastases and establish a world-class interdisciplinary clinic that would enable us to do new clinical research and establish new standard of care for patients with brain metastases. And most importantly, I think what's at the heart of this is how do we serve those patients best, those patients that don't want to be running around the entire institution on different days of the week where every minute matters for those patients. So we decided to establish this brain metastases clinic where the patient is at the center, and we bring the neurosurgeon and the medical oncologist and the neuro-oncologist and the neuroradiologist. We all see the patient together at the same time, and we make a decision on the spot. And I have to tell you, it's always complex. It's why you need everyone, including the radiation oncologist. And we really have one other thing that we're really so proud of that made our patients happy and our physicians happy, which is the patient navigators. Gisela Sanchez William, I just mentioned, and Alyssa Nguyen are basically the epitome of high-touch patient navigation. From the minute they hear about the patient, they start collecting all of the necessary data and coordinating the care for the patient. And it's been just a fascinating experience. So we started in January 2009, initially started with melanoma, and so immediately started going into other cancers like breast cancer. And now we've actually seen over 500 patients. And we started clinical trials that are designed to actually cross diseases. So we have this trial that just started. It has melanoma, breast, and lung cancer, where we treat with targeted therapy plus immunotherapy together. And it's a mechanism that should work in either the three diseases. We have a bunch of really highly dedicated and really highly talented folks in neurosurgery, radiation oncology. From the medical oncology side, we have actually 8 clinicians from 6 different departments. So Dr. Murthy, I just mentioned, myself and a couple of others from melanoma. We have neuro-oncology. We have even phase 1 doctors, Jordi Rodon and Kathy Dumbrava, where we actually are developing, again, new treatments for those patients dedicated to brain metastases. And we think about the clinic as a hub, as a central place where we can bring together clinical trials, but also learn about our patients. So we do biospecimen collection, we do clinical data collection in a database, and we work very closely with preclinical investigators, including, I personally work very closely with them. I'm a translational scientist myself, and really thinking about ways to design clinical trials based on the results that we see from these models, so that we can design them around changing the brain microenvironment. So I tried to go through this quickly because I really value the interaction and the discussion. I hope I managed to convince you that targeted and immunotherapy can be safe, can be effective, that we can induce durable responses with immunotherapy, but that we really need a ton of new treatments, both to increase that efficacy. Say patients with symptomatic brain metastases, we can only serve 4 of 18, 20%. We have 80% to improve upon. And then even for the stuff that works, like Ipi and Nivo, it works, we like it a lot, but it also causes 55% toxicity. So can we generate new things that will actually be less toxic to those patients? And again, at MD Anderson, we've put together this multidisciplinary clinic where we make decisions at the time of care for those patients. And we really think that this would be a central hub for us to develop and conduct new clinical trials and translational research. Lots of people to thank. As I said, from medical oncology, we have 8 clinicians involved. Radiation oncology have been critical to this. As well as our neuroradiology and neurosurgery. And we have some of our attraction colleagues are the people that help design these brain metastasis specific models. And we work with people across the country for this. But again, special shout out and thanks always to Gisela and Alyssa, who really take care of those patients on a daily basis, and really appreciate the opportunity to present here, Dr. Musella. So I'll stop here. You asked me to speak for 30 minutes. I'm a little even shorter than that, but I'm happy to expand on any of those issues, either in response to your questions or to the audience.
Oh, that was very good. Thank you so much. It's amazing the progress that you made with metastasis. Hopefully we'll have that same progress with the GBM soon, because we look like the before pictures now. We want to look like the after ones. Okay, there's a whole bunch of questions. First one is, are you the only center that has a brain med clinic like in that style?
A great question. There's actually several that are starting to happen across the country, and I'm really excited to see that. So Dr. Priscilla Brastianos that I have mentioned here started one at the Mass General at Harvard. Carrie Anders at Duke University also has a brain metastases clinic, and I get regularly questions from other centers on kind of asking us how we've done our clinic so that they can kind of model it after it. And I think that's really where we need to be going with the fact that we have multidisciplinary clinics. The one thing that I think may be unique about MD Anderson is this idea of having so many different medical oncologists from different specialties. So we have, again, a GU oncologist, John Boeng, that's part of this, a two phase 1 trialist, 1 breast cancer, and again, 3 melanoma docs. So by actually trying to cross-pollinate from what we know in different solid tumors, I think that gives us an advantage as well to serve the patients better.
Do you communicate between the different centers, like maybe hold a virtual tumor board once a month?
Yeah, so I have to acknowledge the Duke group that has just started this. We have, I think, at the end of June, our first kind of interactive meeting. They have a conference together, and we're starting to think about this. And I'll acknowledge that they're, kind of pioneering that. I think we're, exactly to your point, Dr. Musella, the whole point is that we need a lot of good brains to come together to figure out how to do this, and collaborations are going to be key. It's not easy to run clinical trials in a multi-center way, but sometimes because those patients are, hard to put on a study, sometimes you need collaboration across institutions.
Are there any such centers in Canada?
Yeah, actually, the Princess Margaret had started a clinic that Dr. Caroline Chung from now at MD Anderson had started all the way back before she moved here. And again, I think they have a multidisciplinary clinic. Different multidisciplinary clinics, I think, actually just have different versions of how much of the medical oncology component there is versus the radiation oncology, but it's definitely something that's starting to expand.
Perfect. That's a perfect model. You have to, you appreciate it more when you see the alternative, which is like complete chaos. Yeah. So very happy with your program.
Thank you.
So when a patient comes into you, do you treat by an algorithm alone, or do you adjust the plan individually on an individual basis?
So yeah, that's a really great question. So we're actually starting to develop algorithms that are specific to the individual diseases. Like if you see a melanoma patient, what are the different options that are available to you? But the truth is there is no clear algorithms to follow. And so we actually personalize almost every patient's therapy based on what we know and what's available. And I consider that also an opportunity to look for when we don't have anything that's medically oriented or systemic, is to actually find out, figure out a clinical trial for those patients, even develop the trials based on the patient's needs, not the other way around. So I'm very committed to that concept. It's not just about a pharmaceutical company coming to me and saying, hey, can you use this drug in patients with brain mets? I want to think about which patients actually need which treatment. And I go out to these companies and say, you need to give us this drug. And it's been a successful approach so far.
Okay, this is a tough one. Say you have 3 clinical trials at MD Anderson that the patient is eligible for. How do you decide which one of the 3 you suggest to put a patient into?
Yeah, that's a great question. It's actually every trial is, if you've ever participated in one or kind of read about them, and unfortunately have a ton of tiny little things that you have to fit called inclusion criteria, and tiny little things that you need to not fit called exclusion criteria that include what's kind of therapy you've had before, what's your, serum creatinine, all sorts of little different things. So we end up finding rarely that we have, one patient eligible for 2 trials. And if they do, it depends on what we know about the drugs themselves and their side effects. And sometimes it becomes an easy choice. If there are 2 trials that the patient is absolutely eligible for and everything else is the same, we share with the patient what are the different side effects and, what would be their preference, and obviously take that into account.
Perfect. Good. Somebody asked, what is leptomeningeal spread, and is that the same as metastasis?
That's a great question. So if I go back, let me try to go back to that slide that I had, because it's best to use an image. A picture is worth 1,000 words. So if you look at, like for this one, you see that this is a tumor that's inside the brain parenchyma. And if you look at how this looked like here, so when you have a brain metastases, it actually, usually when we call it a brain metastasis, it sits here in the matter of the brain itself. Unfortunately, sometimes it gets to seep into this this arachnoid space. I don't know if I'm covering that with her. It seeps into this arachnoid space and start involving the leptomeninges. And when that happens, the entire space that's around the brain and extends all the way into the spine is one open space. So as soon as you have a tumor cell in there, basically that tumor cell can disseminate throughout the whole CNS, the whole central nervous system. So that's why we consider leptomeningeal disease to be significantly different than just the one spot that's inside the brain itself. Even from a radiation perspective, if a spot is in the brain, a regular brain metastasis, you can target it with a focal stereotactic radiosurgery. But if it's leptomeningeal disease, you have to use more whole brain radiation approaches. So it changes a lot. And it's also a harder place to get drugs to as well. So that's why we have this thing called an intrathecal program, where we basically, the neurosurgeon puts an Ommaya, it's called an Ommaya reservoir, but basically it's almost like a port that people use to get systemic therapy, but they put it straight into that ventricular space. And we start injecting drugs from the outside straight into the intrathecal space. So that's, as you can imagine, difficult, sometimes could be dangerous depending on what drug you do. And the fact that we tried immunotherapy there is unique to our center, and it's actually so far been safe, and we're about to show some early efficacy results.
Good, because with the brain tumors, they consider that like untreatable.
Well, yeah, I mean, definitely becomes a lot harder to treat, and unfortunately, the survival becomes a lot more limited as well.
Yeah, there's a new CAR T-cell trial specifically for leptomeningeal spread where we have some hope for, but that's about it. What about proton radiation? Does that have a role in metastatic brain tumors?
Yeah, so I'll acknowledge my limitations as a medical oncologist and not knowing all of the intricacies of every single treatment, but I can tell you proton therapy definitely has value, and it's capable of treating technically with less neurological toxicity, which is kind of the goal. And my colleague, Dr. Jing Li, who's the co-director of the Brain Mets Clinic, is actually leading, along with some of her colleagues, a new trial that's looking at the role of proton therapy. We obviously have it at MD Anderson, but this is going to be in a clinical trial setting.
Perfect. There's 3 other treatments that specifically people asked about. One is, do you ever use focused ultrasound for any of your treatments?
So there is a clinical trial where there's a consideration for using a bit of a focused ultrasound approach to kind of open the blood-brain barrier and allow for more drugs to penetrate. But it's still a very experimental treatment, and we don't use it as a therapeutic approach.
How about Optune? Do you ever use Optune?
So, again, I'm a medical oncologist, so not a neuro-oncologist. I don't treat GBM patients, and to my knowledge, it's not something we've been using at our center. It's obviously an interesting approach, and kind of has its interesting mechanisms of action. So I can see how it could be useful, but to my knowledge, our colleagues in neuro-oncology don't utilize it frequently.
Okay, how about gamma tiles? Are you familiar with gamma tiles?
Yes, and actually, my colleague, Dr. Jeff Weinberg, who's our neurosurgeon, along with Dr. Beckham from radiation oncology, are co-leading a trial that we just started at MD Anderson. I think it's a multi-center trial comparing gamma tile to to post-op radiation. That's the current standard. And so, yeah, I just enrolled a patient to it 2 weeks ago. So it's a really interesting approach. And for people that don't know what that is, it's called tile because it's actually literally like almost like a square piece of almost tile, and that actually has beads in it that are capable of delivering radiation closely. So after the surgeon's done with resecting the tumor, they line the surgical cavity with these kind of delivery of radiation through these beads, almost like brachytherapy, if you've heard of it, outside the brain. And so that's kind of the idea behind that. Really interesting approach, and we're looking forward to see what the results are going to look like.
Can you do remote second opinions?
So this approach has been kind of not as easy to implement at MD Anderson, but different departments have done this, and we're looking at it from the brain metastases clinic approach. The main concern around this is the fact that you need to examine the patient from a neurological perspective. That's always very important. It's hard to do this from a distance. I think even when I'm in the clinic seeing a patient, I defer sometimes to my neurosurgeon for their extensive, skills and neurological, kind of examinations that can help us make a decision for the patient. So that's one of the concerns, that you may not be able to provide the full kind of assessment that patients need. But obviously, the pandemic has opened up these avenues, and we're definitely can do some stuff at MD Anderson in different departments. We haven't implemented it yet in the brain metastases clinic.
Okay. If a patient wants to go see you, do they need a special referral, or can they just call you up?
So you, Alyssa and Gisela, so Alyssa Nguyen and Gisela Sanchez, we're happy to share their emails with you, perhaps through Al. Our primary patient navigators, they can get in touch with you, and then they can work with our access team to get you in. So it doesn't require a different referral. A patient can self-refer, but we definitely look at the different kind of options available and try to bring patients in.
Okay, what I'll do is when I post this to the website, I'll insert the contact information.
Yeah, absolutely. And again,
just email it to me, and I'll do that tomorrow.
She's the one. Yeah, go ahead.
No, I'll have that set up by hopefully tomorrow.
Great.
Let me just check any more questions on Facebook. I think we ran to the end of the questions. That was easy. So we're finished for today. I just want to tell you about next week's webinar. Next week's webinar is going to be a really special one. I'm going to be the guest speaker. I might have a couple of our colleagues talk also. We're going to be talking about the Musella Foundation, the projects we did, maybe a little history about the Musella Foundation, just to set the stage for why we're pushing for these huge FDA changes. We will talk about a patient navigation program, the Promising Pathway Act. It should be really exciting. We're going to make a major change, and we're going to do a big political letter writing campaign. So we're going to need everybody's help. And that's all next week. So I'll see you next week, 7 p.m. Sunday. Thank you very much.
Thank you.
And good night.
Thank you. Bye. Bye.